Hi, today I'm going to show you the newborn exam, head to toe. My baby had an APGAR score of 9 when it was born, so I'd say it's doing pretty well so far. Its respirations are somewhere between 30 and 60 a minute. Its pulse is somewhere about 120 to 160. And its temperature is 97.7 to 99. If it is 99, then it's a little bit warm and might need some layers of clothes taken off. The first thing I'm going to do is, of course, get consent from the parents, even though we've talked about this in several prenatals, and they've already read through the informed consent and signed that they wanted to do a neonatal exam. I would still be getting consent as I went with each step. I'd be showing them what I'm doing, and as I go along, kind of checking in and making sure they still want to do all these things. So I'd wash my hands, greet the parents, probably greet the baby. Just take a general look at the baby and see, how is he or she looking. I probably haven't left since the birth, so I probably have been assessing the baby like the whole time I've been there. If it nursed while I was waiting to perform the newborn exam, I would be watching it nurse and kind of assessing whether it had a tongue or lip tie, how the mom's latch appeared to be, and things of that nature. So, and I'm also like watching, is it breathing well? Is it getting profused with oxygen? Maybe a little cyanosis on the hands and feet, that's okay. But if the whole baby is looking, blue, or it's not looking like it's breathing well, then obviously we're going to transfer it for that. But this baby's been doing well. So now I'm going to do the newborn exam. I would start by touching the little head. I'm going to touch the fontanelles. There's the frontal fontanelle and the parietal. And the frontal one is like a diamond. The parietal one is going to be like a triangle. I'm going to feel the suture lines and just make sure nothing is like bulging or feeling funny. I mean, there might be some overlap because the baby has gone through a birth. It might have some swelling. It might have some molding. I would talk to the parents about all of that. Let's say this is normal. We don't want to be pushing on the baby's head or anything to try to get it back to normal shape. It's even a couple hours later, it's going to be a dramatic difference what the baby's head looks like. The shape pretty quickly goes back to a nice round shape. I would point out the fontanelles. I would talk about how, if the baby gets dehydrated, they can look a little sunken. How it's important for these to stay open for, I don't even know how long they stay open, honestly, but for the first at least 6 months, I know that they're pretty prominent and open, and you can even see the baby's heart beating there usually. And that is important because the baby's brain is going to grow very quickly. So we want those to stay open, so that's good. And you might see some caput, which is swelling of the scalp. It's not a brain bleed or anything like that. It's just swelling of the scalp. And it's caput when it's over multiple sutures. And it's usually kind of covering the top of the head. That's why it's caput like a cat. It's kind of like a cap. So that's important to note. If there is a hematoma, I forget. Anyway, bleeding in underneath the bones and stuff, then you're gonna see it just in one area, and it's gonna be very swollen, and that would be, I would want to go get that checked out. So yeah. And that's going to keep growing instead of getting smaller. The caput is going to start going down. The swelling will go down. The hematoma is going to probably get worse before it gets better. So that would be something to go get checked out. So that's important to note the difference of those. Any, you know, you're looking for any injuries, if there was any, you know, forceps used or a vacuum or anything, you're going to see more swelling and things of that nature. The eyes could also be swollen. Even the face can be swollen on the baby. So it's important to note those things. The hair is important to note. Apparently some genetic anomalies can show up in the hair, and the parts will be weird, or they'll have a weird, you know, pattern to the hair. Like more than a few parts can be a sign of some genetic anomaly. The ears we're going to look at. We're going to make sure the helix is all there and looking good. That the ears are not low set, because that can be a sign of Down syndrome. You want to draw an imaginary line from the corner of the baby's eye to the top of the ear. You're going to see about a third of the ear is going to probably be kind of above that line. And if not, that baby has kind of low set ears. Of course, it can be just a variation of normal too. So some people just have different ears. You want to look, sometimes you're going to note to the parents that the ears are a little bit folded over from just the pressure of like being in the womb, and the way they were sitting in the womb, there wasn't a lot of space, so maybe the ears got a little folded. They'll unfold easily after a while. You're going to like kind of check the cartilage, make sure that is normal. The ear canal is normal. You're not going to be like sticking anything in there or anything to check, but you're just going to take a glance, make a note of it, and make sure there's some ridges in there and things are, you know, developed correctly. So yeah, you might have some vernix and stuff in the ear. That's fine. You can leave that in there, that it will absorb eventually, or like rub in basically. With the eyes, I'm going to use my light. I'm going to try to get the baby to wake up or open its eyes if it's not awake. So you might want to dim the lights, or you can cover, like kind of cover your head, its head like this, make a little shade so that it will want to feel, you know, better about opening its eyes. You don't want a lot of bright lights. Or you can kind of pick its head up a little and it'll probably open its eyes to see what's going on. Then you can shine your light in the eyes to see for the red reflex. Again, if there's no red reflex, I'm going to be sending the baby somewhere. That's not an emergent type of situation, but I would want them checked out pretty soon. You also want to make sure the spacing of the eyes is fairly normal. Like wide set eyes can be like sign of fetal alcohol syndrome, or eyes that are kind of slanted, that can be Down syndrome. Eyes should be about as far apart as the size of one of the eyes is what you're going to see. So that's good. The nose you're going to look at and just make sure the nares are open and, you know, patent. So because babies are obligate nose breathers, they're not going to be able to nurse and breathe if their noses aren't patent. So you're going to note if it doesn't seem like they can breathe correctly. Sometimes, of course, they're going to have some snottiness and some goobers coming out from, you know, fluid from the womb. And of course, you can help with a little bulb syringe or whatever, suck some of that out if you feel like that's appropriate, or if the parents are okay with that. So that's something you can do. Help them breathe a little bit better. There's also the Nose Frida, which I think is really great. It's just another type of suction device to get goo out of the baby's noses. You're going to look and make sure the lips look normal and there's no cleft lip or anything like that. Yeah, that can happen. Then you're going to put some gloves on. Where are my gloves? I had this all set up perfect and I made a beautiful video earlier, and then my computer crapped out on me, so I am remaking it on my phone. I'm not super happy right now about that, but anyway, okay, so I put gloves on, and then I'm going to check the baby's suck. So I'm going to put a finger in the mouth and just check the suck reflex, and the baby should just start sucking. And you can also stroke the cheek over here, and that will cause the baby to turn its head, and that's the rooting reflex, and it'll want to suck on something. So you want to feel the palate inside, and I guess palates are all very different, so feeling a wide variety of palates is good for practice. You want to feel if there's any, cleft palate, obviously, because that's doesn't make nursing very easy. So there's that. And then you're going to also feel for, you're going to check for lip ties and tongue tie, tight frenulum. The baby should be able to stick its tongue out over its bottom lip. Nursing is going to be probably painful and difficult if the baby can't do that. So I know some midwives will clip them right at home with a pair of scissors, and some send them in to get lasered. I don't feel super comfortable. Maybe as I get older and do more, tongue ties, I might feel more comfortable with it because it's getting kind of overdiagnosed right now. I would leave that to the experts too. If I suspected that there was a tongue tie or a lip tie, I would send them in to somebody and just have the laser done, because you can also run into problems of too much bleeding. So the tongue does tend to bleed a lot, but that's something you want to check. You're just going to look for symmetry of the face. The face should be nice and symmetrical, because otherwise, there could be, again, genetic anomalies or some kind of developmental thing that happened. But the baby, in most cases, is going to have a nice symmetrical looking face. They're going to be, moving their face appropriately, moving their body appropriately, hopefully. Okay, and then we're moving down to the clavicles. I want to feel the clavicles because they can very commonly get broken during delivery. So I want to make sure that's not the case. Actually, when you're feeling all of the limbs and everything, you want to make sure there's no broken extremities, because that can happen and it can get easily kind of overlooked. So that's something that we want to be aware of. You can check, make sure that they have 5 fingers, 5 toes, make sure they have the grasp reflex, make sure they have the Moro reflex, which is where you kind of hold them up by their hands and then kind of gently drop them onto the blanket or the soft surface. And they should have a startle reflex where they throw their arms and feet out, and then they will bring their arms and feet right back immediately. And that is the Moro reflex. You want to check that's the palmar reflex where they grab. And the plantar reflex is where they will curl their little toes, kind of around your hand too. And then there's a reflex where I forget the name of it, but you run your finger up the foot like this, and they will spread their toes, which is not something you want to see in an adult, but all these reflexes disappear between 3 and 4 months of age, so they're called primitive reflexes. And there's a crawling reflex where you turn the baby over, put its arms kind of like this, and it should start doing kind of crawling movements. Babies can actually do something called a breast crawl, where they crawl up to the breast right after birth if they're left alone, and attach themselves to the breast, which is pretty cool. There's a stepping reflex. We set the baby down and it will feel on its feet. It'll make kind of like stepping movements if you hold it up. Obviously its head is wobbly and everything, so you're holding the baby up. And then there's the other one where you run your finger down its back and it should turn, and I forget what that one's called too, but it turns toward the side that you are touching like this. So those are the reflexes. All these reflexes kind of tell you that the baby is neurologically developed and that it is developing the way it should, and it's kind of, it's neurologically developed. And you're also, of course, looking at the tone of the baby. Is the baby well flexed? A full-term baby is going to be really well flexed like this, you know. And a premature baby is going to be more just laying like this, like just splayed out. So yeah, it's important to see that well flexed tone. And you're going to, you know, do some things to check its tone. Might move its arms out like this. Watch it flex back like that. Or move its legs. Watch it flex, etc. So those are some of the ways you can check that it's neurologically developing correctly, and you know, the reflexes, and then it's able to nurse, and all those things are good signs that the baby is where it should be, is doing great. Okay, now I'm going to look at the nipples and the chest. The nipples might be a little swollen from the hormones of the mom. It might even produce a little bit of what they used to call witch's milk. That with boys or girls can do that. That will go away in the first like week or so. So you want to tell the parents about that, not to be alarmed. It's just a normal, you don't need to like express the milk or anything like that. It's just a normal thing that happens and it will go away. You want to make sure the sternum looks, and the xiphoid process might be a little bit protruding. That's very normal in newborns. So you want to tell the parents that. The sternum looks nice and flat, not, you know, not too concave or anything like that, because that could be indication of a problem. You're going to palpate around on the abdomen. Just make sure there's no abnormal masses, lumps, bumps, anything that indicates a problem. You're going to check around the umbilicus. You might have an umbilical hernia. They're pretty common. If you can sort of reduce it back manually, then it's going to be okay. And if not, there might be an abdominal malformation that might need to be taken care of. The umbilical hernia, if it doesn't go back on its own, which some do, by age 4, you know, a doctor will fix it. You're going to look at the umbilical cord. Hopefully it's not oozing anything or, you know, weeping a lot of blood or anything like that. If it is, that is a serious issue and could be that they are low on vitamin K. So, yeah, that's something that's a vitamin K deficiency bleeding sign. So that would be to rush them in. You're looking at it should have 3 vessels in the cord. So you're looking for that. And then you're going to come down, you're going to take off the diaper, you're going to check out the femoral pulses, and hopefully those are nice and strong and even on both sides. Yeah. Oh, I forgot to listen with my stethoscope too. So I'm going to be wanting to listen to the baby's breathing and lung sounds and heart with my stethoscope and bowel sounds. So it's going to be, it might be difficult to listen to the baby's heart and hear all of the sounds at first, because the baby's heartbeat is so much faster than other people's heartbeats. So that can make it tricky. You might have to listen for a while to really get a feel for the heartbeat and hear the full cycle, the lub-dubs, you know. And you might hear a murmur. That's pretty common too. A lot of newborns, their pulmonary, I forget. But they're, one of those stenosis has not shut correctly yet. So that's very normal to hear a murmur. You'd want to note it. And yeah, if there's any other signs of like cardiac problems, obviously get it checked out. You're going to listen to lung sounds. You might hear a lot of crackly respiratory sounds, but hopefully nothing down in the lungs, because they're still spitting up all that amniotic fluid and everything that they swallowed during the birth. So yeah, the breathing is going to be a little funny, and there's going to be a lot of noise maybe with it. But the lungs should be sounding pretty clear. You're going to listen for bowel sounds. Hopefully the baby is nursed already and there's some bowel sounds. You might listen for a while just to make sure you're getting good bowel sounds here. Okay, and then you're checking the femoral pulses, or the femoral pulses down here, making sure they're pretty even and strong, and yeah, about the same on both sides. If not, that could mean a heart defect, so you definitely want to do that. You're going to want to look at the genitals. If it's a boy, you're going to want to check for hydrospadias, and make sure that the opening of the urethra is, you know, in the middle on the top of on the head of the penis. You don't want to retract any foreskins or anything like that. Again, with the foreskin, you're just looking to see that the hole is in the middle, or on the very tip, you know what I mean. The balls, you're gonna feel them. You should feel 2 testicles. They're gonna be like little marbles. Hopefully they're descended. If they're not, it's not really a big deal either. I think doctors will help bring them down by age 3 or so if they haven't descended. But yeah, it's not really a big deal because sometimes they don't right away. You're looking at the rugae of the testicles. They should be pretty not smooth. They should have a lot of rugae on them if it's a full-term baby. So that's another way you can look and see if the infant is a full-term baby, by looking at how developed the rugae on the testicles are. For a girl, you're going to be looking, you probably won't see her clitoris. Her labia should be developed enough so that's kind of covering her clit. Her genitals might be a bit swollen. Boys too. That can be from, like, if they're from birth, from the pressure of birth, and also from the hormones. So you're going to look and notice that. You're going to tell the parents of a girl that they might see a little bit of blood or like white discharge in her diaper. Not to worry about that. That is totally normal. It's like a pseudo period. Again, it's kind of like the witch's milk in the breasts. It's the hormones of the mother leaving the baby's body. So there's that. You're going to look to see, I would do this when I flip them over. You're going to look to make sure the anus is patent. And it appears that it is, so that's good. Because there are some genetic anomalies where babies are unable to poop, which is, of course, very serious and requires surgery. So you need to check that. And also, I always ask when I come back, like on day 1 and also day 3, you know, wet and messy diapers, like, are they having both? And usually people say yes, but if they're not pooping, that's very serious, and you should probably take that infant in, because something is wrong if they're not pooping. And they'll stop eating after a while. They won't feel good, obviously, so yeah, that's not a good thing. You want to check to see if the hips are dislocated, which can be a common birth injury as well, especially if the baby is breech. I guess it's not really a birth injury because it usually happens while they're still in the womb. They're sitting so long, their legs can become dislocated. Females and family history all lead to more dislocated hips. So the way you check to see if the hips are dislocated, you're going to put their feet flat down on the surface, and you're going to look at their knees, and the knees should be approximately the same height. If they're not, then that is a problem. And then you're going to also rotate them thusly to see if you feel any clicks or any grinding or popping or anything like that when you're moving. You're feeling with your hands. You have your hands here on the hips, and you're feeling to see if you're feeling anything like that. But you're also looking at range of motion And you can also like bring their legs up and see how high you can get them. And of course, a premature baby is going to be much easier to fold than a full-term baby. That's going to be a little bit more, have better tone and things, and is not as bendy. So that's the other thing you can do. With the feet and the legs, we talked about the stepping reflex and all that. I'm going to want to turn the baby over. I want to feel its entire spine. I want to make sure I don't feel anything like curves or, you know, anything out of place that's not normal, or missing pieces, or, you know, anything like that. We want to look and make sure there's no tufts of hair down here at the bottom towards the butt, or any sinuses or anything like that. Dimples, those can be signs of spina bifida. So we definitely want to look at that and note that. You want to look and see there's sometimes birthmarks, dark pigmentation, especially on darker skinned children. And you want to note that too, because those can be misconstrued as child abuse, as like bruises. So if it's something that you note, then it'll be in the medical record and they'll know that it's been there since birth, and it's not anything like that. It's something they were born with. I am forgetting things. I'm trying to think. I guess that's it for like the back side. I want to like make sure the back of the head is, you know, there's no open areas, nothing like that. You're not noticing any, you know, missing patches of hair or weird open things. And that's true for the whole body. When you're looking at the body, you're looking, you know, making sure the skin is all intact. Everything looks, you know, the way it should. And you're noting anything that is not the way it should. And then you are sending them to a professional if it's something, you know, if it's something serious. There's also the scarf sign, I think I forgot, where you cross the arm over the baby's chest to see how far that can go. And in a fully developed newborn, it's not going to go very far. In a preemie, you're going to get it all the way, you know, across the chest like that. There is the square window sign where you bend the wrist down. And in a full-term infant, you should be able to do that. And a younger one, you cannot. So there's that. Yeah, I think that is pretty much the entire test. I'm trying to think if I forgot anything. Oh, I did. I forgot quite a bit, actually. You want to, of course, weigh the newborn. I don't have my fish scale yet. I have not acquired one yet. I do have a sling. So we usually use a sling as midwives to weigh the baby. You just want to get them in there. Negative possible is good. Then you know exactly how much they weigh without any clothes or diaper or anything on. And the dad could do the weighing as well. It's very simple. You use a fish scale to find out how much the baby weighs. And a normal newborn is going to weigh somewhere between 5 and 9 pounds, roughly. There's a wide variety of weights that are, I mean, I think 5 is that's kind of small. Home birth midwives are going to see, you know, around 8 is pretty average. So we might see smaller with, you know, some populations, but okay, you're going to measure around the baby's head too. And again, I don't have the best measuring tape here, but you measure around the frontal bone, around the occiput, and it's going to be roughly 13 inches. Well, 13 inches? 13 centimeters. I mean 13 centimeters. They're not 13 inches. So this baby is obviously very small, so it's not going to approximate that, but yeah. You measure your head. You're going to put a Chuck's pad down that you can draw on, and you're going to measure from the top of the head down to the bottom of the feet. You'll stretch the legs out, which the babies do not like. And I think that's it. Yeah. And of course, you know, I talk to the parents about anything I find and just make sure they understand everything we went over. And, yeah. And then follow up with things, any questions they have in the next couple of days when I come and visit again at 1 day and 3 days. I would be looking again at the umbilical cord, making sure that's drying up good. I'd be looking at how the baby's feeding again, asking about wet and messy diapers, and weighing them again and making sure they're, you know, gaining weight appropriately. Though, of course, at first, the baby's going to be losing a little bit of weight, but they eventually do gain it back, usually. And that's it. That's the newborn exam.